Well, I want to welcome everyone today. Good morning, good afternoon, good evening, whatever part of the world you're in today. Real treat and pleasure on behalf of the Tumor section that we're initiating a series of webinars focusing on education and neurosurgery and a variety of topics. And what a great way to start this with a mentor, a colleague of mine, Dr. Mitch Berger, who's really a world expert on brain mapping. Dr. Maria Noor Al-Huda from Pakistan. She's going to provide a few words on Dr. Berger, and then we're going to jump right into his amazing talk. Please reach out with questions with the QA. If you feel the need to use the chat box, that's fine too. Maria?
Thank you very, very much, sir. I'm really honored. I'm really excited to start this amazing series, and I'm really grateful to Professor Constantinos for this huge privilege. And this is extremely important series. And I'm so much excited to introduce Professor Mitchel Berger. Obviously, he doesn't need any sort of introduction, but I really wish to say a few words. That obviously we all know that Professor Mitchell Berger is one of the pioneers of intraoperative brain mapping that was certainly a game changer in glioma surgery. We obviously know this. And he's a prolific researcher with numerous research papers, and he has spent on several book chapters and as well as several books. Many of us have already read them, and we know him very, very well. And also, he's the winner of the Win Prize. And currently, he's the Berthold and Bell Guggenheim Professor and the chairman of the Department of Neurological Surgery, as well as the director of the UCSF Brain Tumor Research Center. He has held top leadership positions, including the presidency of the AANS and the Society of Neuro-Oncology, and the vice presidency of the CNS. So it's a huge privilege to have you, Professor Mr. Berger, with us today. Thank you very, very much for accepting our invitation to deliver your wonderful talk. And the floor is all yours, sir. Thank you so much.
Okay, thanks, Maria. Thanks, Costas, very much for this great opportunity to be here with all of my friends and colleagues around the world talking about a subject that's very, very important as a glioma surgeon. So I'm going to share the screen and try to do this. Let's see. Do you see this?
Not yet.
Not yet. Okay, so let's see what the problem is. Let me share.
Oh, now something's happening.
Okay.
Okay.
How about that?
We can see it now.
Okay, here we go. Let me just move this over to the side. Okay, so what I wanted to do today is really get into some of the nuances of brain mapping. This has been, I think, a very interesting learning experience. I've been at this actually 39 years. I did my first brain mapping case in 1986, and things have changed significantly over the years. And I'm going to sort of take you through my personal journey of brain mapping. And I think it really starts with the philosophy that when you begin your career, as I did, you really need to have sort of a purpose as to what it is you want to achieve. So as a tumor surgeon, my main interest was in maximizing the extent of resection to increase survival. But of course, the critical thing was to make sure that it was done safely. And in the beginning of my career, biopsy was really the standard of care, but the risk profile of doing some of these biopsies was really very, very high versus the idea of doing a complete resection. So the goal was to change the risk profile and to make tumor resection less risky than doing a biopsy. And I want to show you exactly how that happened. I think you can't really give a talk like this, and I'm not going to get into extent of resection, but you can't give a talk like this without really trying to frame the reason why extent of resection is so important. And I'll just cut to the chase and show you two significant papers that we've published in the last few years, both on high-grade gliomas and on low-grade gliomas. And essentially, in a single series, in my own experience, this is clearly indicative of the fact that if we achieve not just a gross total resection of the defined tumor, but we go beyond that to achieve a gross total resection plus, some individuals call this a super total resection, then I think you can see the survival curves continue to shift upward on the left for glioblastoma as we get into less residual flare and as we get beyond the flare for the low-grade tumors. So if the goal, and if you believe in that, then I think you have to figure out a way to do it safely. And it turns out that there are a lot of institutions now around the country participating in the world, participating in the RANO-Resect group, of which we're a part of. And again, from our own institution going beyond into the experience throughout the world, we've all continued to show how extent of resection influences outcome. And so now it's actually bubbled into the template for many of the national and international organizations, whether it's SNO, ASNO, EANO. We're all on the same page now that extent of resection is really critical and that you have to achieve that, especially if you can get a super total resection. So if a maximal safe resection is your goal as a glioma surgeon, which we now know it must be, then how do you achieve this in the safest way possible? And the safest way possible is not an anatomical based resection. It's really a functional based resection. And that's where brain mapping comes in. And I'm going to go through this process of how this was all developed and how this was sort of put into place. And when I think about it, as I was thinking about doing this talk, I realized that going back into my career when I started, I really did not have a lot to draw on. There were only two articles that talked about any kind of mapping, and it was cortical mapping to help aid in the extent of resection of gliomas. So there wasn't really a lot to draw from, but there was indications in our history of neurosurgery with Penfield, who had really developed a lot of the direct cortical stimulation techniques, and Norman Geschwin, who was a cognitive neurologist, neuroscientist, who really came up with the concept of connectivity as it related to the organization of the brain. So we had the substrate, excuse me, we had the substrate to do this. And now the question is, how do you put this together? Well, like a lot of things in life and in the career, you really have to have good mentors. And I had a great mentor in George Ogerman. When I went to the University of Washington for my first job late in 1985, early 86. But what I realized, and this was the first time I had ever seen an awake craniotomy, I realized that this was really mostly designed for epilepsy to define cortical-based function. And of course, in the tumor realm, we're more interested in not just the cortical representation of the tumor, but chasing the tumor in the subcortical direction to try to maximize extent of resection. So early on, the basic tenet and the substrate for doing awake craniotomy could be found in epilepsy surgery with people like George Ogerman and Andre Olivier in Montreal. And of course, those roots came from Penfield. So let me just explain what brain mapping is for those of you who understand it or think you understand it, but the principles of it really are twofold. We're using an electrical current to evoke a function, such as movement, sensation, or visual scintillations if we're working around the optic system, or we use a current, excuse me, to stop a function. And by that, I mean persons counting or naming objects, and we can see exactly when stimulation of a certain area, whether it's cortex or subcortical area, will result in the interruption of a function. So again, we use electrical activity to evoke a function, but we also use electrical activity to inhibit a function. And I've been developing a new digitally based mapping strategy, and this is a tool that's coming out that can do both high and low resolution or low frequency mapping for cortical and subcortical detection of function. We're about to submit this to FDA for approval. So I hope this is going to be available next year. It uses a very digitally based system where you can stimulate, you can replace the tips. It's portable, it's battery operated. It has an iPad that will have algorithms that will communicate with you about EMG responses, about language responses. So this is a new technology that's going to emerge because, as we know, the Integra company has discontinued the Ogeman stimulator. So you have to have a new way forward with this. And I think this will do it very nicely. Okay, let me show you what the workflow looks like when we're doing the mapping before we actually get into it. In essence, what you want to do is you want to expose an area of the brain that you're going to be resecting with a little bit of a margin. And then you're going to begin to interrogate with stimulation, in this case, to look for function where we're evoking a motor response, or we're doing sensory stimulation and we're defining, in this case, the Rolandic cortex, the motor and the sensory system. And then what we want to do is we want to look for motor speech and then, of course, do naming. And the way this all has to happen is we're going to stimulate, as I'll show you, we're going to stimulate, we're going to interrupt function on the cortex, and then we're going to present the stimulus to the individual to respond. So it has to be in this fashion, whether you're using naming, reading, or any type of a language-based task. You have to stimulate the cortex or the subcortical region before the individual sees the task. There are a lot of different tasks that you can use, and you're going to read about and hear about a lot of different ways to do mapping. But in my experience, there are only 4 tests that I use for the entire cases that I do for mapping. 2 for cortical function, that's naming and reading, and 2 that I'll show you for subcortical localization of the ventral stream, like the IFOF, the ILF, and the dorsal stream, like the arcuate fasciculus and the SLF. So there are 4 tests. Otherwise, you can look at different kinds of tests that regard syntax, writing, parietal lobe function, whatever it is you want to test in that area of the brain specifically, you can test it, but you have to go into it with the tests in mind so that you know exactly what you want to do when you start the procedure and you have the test ready to go. There are different issues that come up when you're doing the mapping. I've encountered many of these through my career. I'll give you just one example of patients who I think we've stimulated early in the career. In my career, we used very high currents. It evoked seizure activity, and we were able to suppress seizure activity by using cold Ringer's irrigation. It's basically a cardiac solution that's ice. We break it up, we put it on the table, we use it to irrigate the cortex if there's any seizure that's starting, to abort the seizure without having to use medications that cause sleepiness. So this is just one way of doing it, and I would suggest you look at this article, which really chronicles the way in which we've dealt with a lot of things, such as patients who are overweight, who have high BMIs, who have mass effect from swelling or hypervascularity, et cetera, et cetera. The bottom line is that there is really very, very few instances where you cannot map a patient awake or asleep. So you never have to abandon those procedures because of seizures, because of BMI, or hypercarbia or things like that. There's always a way to troubleshoot that. My technique is fairly standard. Over my 40 years of doing this, I will do an awake procedure followed by an asleep craniotomy, where I put these patients down. They go to sleep when I'm doing some of the resection. I'll wake them up if I have to do subcortical mapping, and then I can wake them up, keep them awake for the resection, the following resection, or I can put them to sleep. But basically, I like to put patients to sleep first, do the exposure, get them awake, either put them back to sleep, wake them up in different stages, depending on what I'm doing, and then at the end, put them to sleep for the procedure. I don't use a laryngeal mask very often. I will only do it for very young people who are intimidated or frightened by the process, where we can use an LMA and get them awake after the opening. The only reason why I don't like to use an LMA is because sometimes the effects of the anesthetic linger a little bit too long, and I prefer to use propofol or dexmedetomidine to just open this up and get the patients awake, and to stop that medication so that within 5 to 10 minutes, you're really in the middle of mapping. Now, the other thing you have to do is you have to be flexible with the anesthetic agents. I mean, this week alone, I did 3 mapping cases, and during those cases, I had switched the anesthesia in all of those examples because the patient became disinhibited with propofol. So I had to use a combination of remifentanil or dexmedetomidine, or I would just use remifentanil alone, because those other 2 sedative hypnotic drugs were really causing disinhibition. So what you want to do is you want to start the medication, propofol, remifentanil, watch the patient, make sure they're calm, they're asleep, and then you can begin to infiltrate the skin and do the opening. If they become disinhibited, you can stop the medication, you can take them out of pins if you need to, and then get them back together depending upon whether you have to use dexmedetomidine, remifentanil. And on very rare occasion, I will only use a local anesthetic if a patient is very, very anxious, and keep them completely awake. This is the setup I have in the room. It's fairly standard, where the neurophysiologist is on the other side of the drape, and I have my navigational workstation and my ECOG people, the neurologists who are monitoring the electrocorticography in the back of the room. And this is essentially how the setup occurs, so that we can do the testing, and the testing station is on the other side of the drape with the neurophysiologist. Now, the new system will have an iPad with a Bluetooth capability and an AI algorithm that will actually speak to the surgeon and let you know when the patient is correct versus incorrect in naming. So we're working on that now as the 3rd generation. These are the basic principles. You essentially are going to anesthetize or infiltrate with lidocaine and marcaine the incision you're going to make. So you basically draw the incision on the skin, and then you do a 360-degree block around the incision wherever you are, wherever you want to do this. And then you have your cold irrigation ready to break the seizures that I showed you in that video. And then if patients snore, I like to use a nasal trumpet so that it gets the uvula out of the way and they don't snore as much. Okay, so these are two of the tests I use. This is a naming paradigm that we're going to use to interrogate both cortical and subcortical localization. We'll use words for reading, and those two are the basic cortical functions that I'll test. I'll show you the subcortical functions, and I'll show you examples of this and how it works. Again, keep in mind that you must be able to stimulate the brain before they see the task, and then they see the task while you're stimulating. They tell you the answer to the task, and then you remove the stimulation current. That all has to be done in 4 seconds. Because if you leave it on more than 3 or 4 seconds, the likelihood is you're going to get a seizure. So you're going to stimulate, the task appears, they say it, you take your hand off the cortex or the subcortical region, and then you move on to the next location. As far as the subcortical localization is concerned, we've published a lot of this in terms of what those critical connectivities are as they relate to the ventral stream and the dorsal stream, and I'll review that for you. The technique that I use is while I'm resecting with the cavitron in my right hand, I'll be stimulating and mapping in my left hand, and we'll be showing the patient the tasks. They're awake at this point in time, and we're going back and forth, resecting, stimulating, and looking for the ventral stream and the dorsal stream. So if you want to find the inferior frontal occipital fasciculus, one way to do it is to stimulate the white matter and look for stimulation-induced semantic paraphasias. Or you could show them this picture word interference test where you tell them to read the word that's similar to the picture. In this case, it would be rabbit and horse, 2 animals versus the horse and a vegetable or a fruit. And if they can do that, you can do the related task or the unrelated task. But basically, these are the 2 ways to interrogate the IFOF. And then if you want to know where the dorsal stream is, the part of the SLF, temporal parietal portion, or the arcuate fasciculus, you can look for stimulation-induced phonological paraphasias, or you can show them this sentence of an action phrase like the couple are dancing, or she is writing a letter. And if you stimulate the white matter and they're unable to tell you that, then you know that that is in the arcuate fasciculus or the SLF. So those 4 tests, 2 cortical, 2 subcortical, are what I use for every mapping test that I do. Okay, and this is a good example of where you would see this being very relevant. You see the cortical map here. This is a tumor in the posterior aspect, the superior temporal gyrus, inferior parietal lobe. You want to do this resection. As I'm doing the resection, I have a stimulation-induced phonological paraphasia because I'm getting into that dorsal stream. And I stop at that point, and you can see very, very clearly where that residual area is underlying the resected portion of the superior temporal gyrus. And this is what it looks like using a DTI map, showing exactly where I stimulated in relationship to the preoperative DTI to show you that stimulation-induced phonological paraphasia is a way to identify the arcuate fasciculus. And in this case, it allowed me to stop before I have to do anything else that would result in transection of those pathways. Okay, so as I started to look at all this information when I was at the University of Washington with George Ogerman, we put together the largest series of language localization in patients that was ever recorded, published this in the Journal of Neurosurgery. And basically, we define the fact that if you're going to find the basic tenets of the language system that deal with not just motor speech, but with comprehension and reading, that it's going to be in the perisylvian networks. And this was based on a study where we stimulated, we recorded the percentage of errors, and then we created these probability maps of where we would find function. So this was a very good way to get a sense of where you're most likely to find cortical-based language. And we learned a lot of things from this study, but the two things we learned, I think, that were more important than anything else in my entire career of 39 years of doing mapping was that we never saw two patients who had the same language pattern. Language is variable in everybody. I've never seen two people who have the same exact language localization cortically. Subcortical is very, very different, but the cortical localization is variable. Therefore, you must map everyone in all these perisylvian networks separately. And if they have more than one language, you have to map more than one language in the perisylvian networks. And the other thing that we learned from this that was initially that we had to do a large exposure to find a positive site, meaning an anomia or a speech arrest or some kind of a reading deficit, right? Because that was a positive indication that the mapping was working. The problem with that initially was it resulted in these very, very large exposures. And so now, as I'll show you toward the end of the talk, we've limited these exposures very significantly. All right, so I'm going to show you a couple videos. They're 2 minutes each.
Most important parts of
And
this is the preparation.
You may be able to
So
hear
we
some of this, but
map
I'm
it,
going to talk
start
over
respecting
it.
Be presented
But
with
essentially,
the
this is how I would line up a
seizures.
patient and do an
Basically,
awake
it's just a
mapping
real
case
focus.
of a dominant hemisphere
Sketch your
supplementary
vision.
motor area
So,
tumor. The reason we do this
really nice
is because I
young guy.
want to detect language
40.
as it relates to the middle
Plays a
frontal
lot of
gyrus.
soccer.
So if I extend my resection
Left.
more than 4 centimeters off the
Well, that's
midline,
language.
I really want to be able to have that patient awake. It's not just a motor mapping case, it's language and motor mapping. And so you'll see this is my exposure. I've drawn the area of the tumor over the bone in front of and behind the coronal suture, which is that perpendicular line. And I'm going to turn a flap just on the midline and then open the dura.
See any high
And
grade features.
my approach to opening the dura is that whenever I see a cortical vein, if it's in a very critical area, such as over the motor cortex, I'll just cut the
Everything's
dura
going great,
around
Robert.
that. All right, we have the
Got
tumor
everything ready to
exposed.
go, and
I have a strip electrode
we're
in
gonna just
under the
start
dura
taking this out.
on the
First, we
motor
gotta
cortex,
test your movement
and we're going
your
to
length.
stimulate that strip, and we're going
There
to
you
look
go.
for motor movement.
On.
And we find that very, very easily.
Bilingual. We'll try naming
And so
in
the
English
strip
first.
defines the motor
So I'm
cortex
gonna
under
stimulate
the
before
dura.
he sees the picture.
Now we're going to stimulate and look for language dysfunction. So I
29.
want you to notice how I do this. I'm going to stimulate first and then show the task.
28. Okay, so do you want to do
And by
naming
doing that, the patient can't actually remember the word.
35?
So I can temporarily interrupt the function of that cortex
36?
before they see the picture.
Okay, reading.
And then we're going to do reading.
34?
Again, I'm going to stimulate, and then I'm going to drop the word down, little,
32?
and they see that.
Okay, we're gonna bring the scope.
Okay, and then I've tested that patient who spoke 2 languages. I tested him in both languages.
Correct.
Now I'm going to do the resection. And the way I tend to do the resection is I hold the cavitron in the right hand and I map, or I use the bipolar in the left hand, or I map in the left hand. And then every once in a while, I'll stop and I'll stimulate with either low frequency bipolar stimulation, as I'm doing here, or as you'll see in another short video clip, using high frequency monopolar stimulation, which I find more reliable for subcortical motor and language mapping. And we'll just continue this until basically we have the end, and you'll see what the patient looks like
So we got a nice clean resection.
at the end of the procedure. They're starting to develop a supplementary motor syndrome.
Open.
So it's very
Move your
slow,
foot. Move
but
it.
they have full function.
There you go. Good.
And it takes several days and it may be up to a week for this to resolve the SMA syndrome, but it resolves. And this comes back because all the motor system was intact. And this is basically what you want to achieve at the end of a resection like this. Let's look at another case that's more of a
The
pure
outline.
language case. This is a temporal lobe
The
lesion.
goes way up.
You see I'm drawing the
Sylvian fissure.
lesion overlying
Whoops.
the scalp. I'm going to do my incision, which I've blocked in a 360-degree fashion anteriorly along the forehead. If I need to infiltrate the muscle while the patient is asleep, if they feel it, you can re-infiltrate the muscle. And we're going to turn the flap and open the dura. And then the
My
standard
strategy first.
process
Find the area you
is
wanna take out.
put the
Narrow,
numbers down,
Map that area.
look at what you
Don't
want to
just
remove.
map
In
the
this case,
entire
it's
area,
all the way
and then
back
decide
to the
what
vena
you
labae
I know
posteriorly.
going into this what I need to take
But
out.
I've got to map this
Oh,
entire
pour a little
area.
water first?
Patient's awake,
Don't give them
and
that
we're
beer.
going to get the patient really at a good point where he's reasonably happy, not in pain,
Crown Royal?
cooperating. And you see the TV screen, which is going to show him the pictures. Okay, so stimulate, sees the picture.
45.
Okay, we're going to stimulate down on the cortex first, and then we're going to show him the picture. And he
44.
says it's a leaf, so I know if I do that
Oh,
3 times,
28.
and there are no errors doing it 3 times, that site is
Man.
acceptable to
47.
remove. And so we'll test reading. In this case, we're going to
33.
test sentence generation. Make sure they're able to do that.
Woman running.
The woman is running.
43.
And so we're going to do this entire map, and each one of those pictures
27.
is tested 3 times. This is picture word interference.
26.
You can do it, as I said, in a related or unrelated fashion. Okay. So now we're going to first coagulate the cortex. We're going to do the resection and continue to do this and resect downward. And I'll get to a point in my way of thinking about it is when you get to the point of the U fibers and lower than the U fibers, that's when you want to begin to look for the subcortical pathways, and you'll do the stimulation. So now we're doing low frequency stimulation, which I prefer for subcortical language mapping.
Hammer.
He says it's a hammer, but now we're going to show him other tests. And then eventually you're going to see that I find a subcortical site for interruption of naming right here.
That is oh shoot, I know that big time too. All right.
So he couldn't tell me what that was, and that was a helicopter, and I had found that portion of the subcortical system of the inferior part of the SLF at that point. Okay, so this is what that resection looks like for a high-grade tumor. It's a nice clean out, language is preserved, and that's where we are. And just because I don't want to neglect the fact that we do a lot of motor mapping, I think it's really important to understand that you can do motor mapping with patients awake. And I try to do that with these surface-based electrode pads versus using needles for EMG when the patients are asleep. And we now use a combination of what I have called and published recently called triple motor mapping, which uses low frequency bipolar stimulation, that's the Penfield technique, versus high frequency monopolar stimulation, which is the technique that was popularized mostly by Lorenzo Bello. And that plus the use of continuous motor evoked potentials either through the scalp or with a strip electrode on the cortex allows you to be able to do this testing in 3 different ways. And this gives you the greatest degree of assurance that you're going to reduce your morbidity and keep it under 1%. And actually, the only morbidity I ever had using this technique was not transecting the motor pathways as seen by DTI. It's causing little perforator ischemia if there are deficits, but these tend to be very, very minor deficits. And the DWI ischemic areas, I think these are more or less to be expected in a few percent of your patients. You have to very carefully avoid using bipolar coagulation at the bottom of the cavity because of this. I just put a patty on a bleeding site or use some flow seal to stop the bleeding. Okay, so basically we're at a point now after several decades of doing this where brain mapping really became the standard of care in neurosurgery. We published this in the New England Journal of Medicine. We showed and we confirmed the variability of language localization. But one of the things that I showed as time went on was I didn't need to rely on a positive site. And this is what I refer to, and some of you may have heard me say this, as negative mapping. Negative mapping means you can do a very focused exposure. You don't have to get a positive site to believe that your mapping is functional, meaning as long as you're using the techniques that we talked about with monopolar high frequency, or you can use low frequency bipolar stimulation, which is what I start with cortical language localization, as well as subcortical language localization. Body temperature is over 36 degrees. Patient's fully awake. As long as you do that and you get negative mapping, you can go to the bank on that. You can rely on that, and you can go down and do the cortical followed by the subcortical resection. We've shown that variability of language is something that has persisted to this point in time. This just shows you a paper we published showing you the probability and the variability. So the probability in red of finding speech arrest, probability of finding areas that deal with comprehension of language, and then in green, the variability of finding that. So it's not hardwired, and everybody is clearly different. And this is what I mean about focusing the exposure from these very big exposures that I did, you see on the left, way over on the right, to very focused negative mapping, and relying on the negative mapping to make my cortical incision and to do the resection. Together with Hugh Defoe and other colleagues, we showed that if we use the mapping technique, we can reduce the morbidity by 50%. We've shown that the language localization and the strategies used can be used all over the world. We proved this with the same language mapping paradigms that Hugh and I have used for years. Jinsong Wu has used this in Shanghai. And basically, we see the same data in terms of the perisylvian networks of language localization, regardless of the language used. So we were able to show very, very clearly that we could detect subsurface language localization. This was a very big issue about halfway in my career, where I realized that I needed to not only do cortical, but subcortical localization. I worked on these techniques and basically boiled it down to those 2 critical tests that we do for the ventral and the dorsal stream. But the bottom line is I still didn't know how all of these areas were connected. And so I started working with the cognitive neuroscientists at Berkeley. And eventually we published a paper in Science showing that based on high density recordings off the cortex, that the communication scheme from one site to another, say from Broca's area to the region of Wernicke's area, was really through very high gamma activity. So we're talking about frequencies of 65 to 150 hertz. These are activities we can use to identify connectivity, and we can monitor that during the course of resections. And I'll show you exactly how that works in this picture. So for example, if you want to do a test with verb generation, so you tell a patient, tell me the verb that you associate with the noun ball. You can kick it, you can hit it, you can throw it. This is how the whole thing works. So this is from a real patient with information from the grid transposed onto the MRI scan, where I say to the patient, okay, I'm going to give you a noun. In this case, it's ball. And when they hear it, you activate over the auditory cortex. Then you process this information in Broca's area. You think about what you're going to say. That's active. That becomes silent. And then you say kick or hit. That becomes active. And this is a loop, a connectivity loop that we monitored and measured with high gamma activation very, very nicely. And we showed at this point in time, and this will basically be my last slide, because I want to stop for some questions. But at this point in time, really having done this now for nearly 4 decades, into my 39th year of doing neurosurgery, that we've been able to show that brain mapping is a very reliable technique. It basically is used to maximize tumor removal, minimize surgical risk. It allows us to identify where speech and language is located on the surface. Using these 2 tests, we've been able to understand the localization subcortically with the other 2 tests. And we've shown that the high gamma activation really is the substrate that connects these areas. So this is basically how I'll end this now, and I'll stop the presentation, but I just wanted to give you that overview so that we have some time for questions in the remaining time we have. So I'll stop sharing there.
Okay, wonderful. Excellent presentation as always, Dr. Berger. I think, every time I hear you lecture, I learn new things all the time. And as you know, I spent time with you personally after I finished my residency. So, and I cherish that time with you. We are going to see if we can have some questions thrown out here. One question I had as we start this up here, and I know you have about maybe 7 or 8 minutes here.
Yeah, 10 minutes is fine.
10 minutes. Okay. So we're kind of moving into this era of, this connectome and connectomics work, where we're trying to understand these hubs and function and planning for surgery, et cetera. Obviously, mapping, subcortical mapping in your practice and most of our glioma surgeons' practices are gold standard. How do you see that being incorporated kind of in what we do on a daily basis?
That's a very good question, Costas. I tell you, I've been extraordinarily disappointed in the use of these connectivity strategies preoperatively, because they're based on resting state fMRI. And they're based on these presumptive ideas of connections using resting state activation, which is really based on extraction of oxygen or changes in oxygen concentration to give you the signals. And when I've tried to use that information and correlate it with intraoperative mapping, I find that everything breaks down. You can't rely on that information at all. And in fact, the folks who tend to think about using this as a way to substitute, meaning they're saying you don't need awake language mapping, you can just use resting state connectivity, connectome maps as a substitute. Well, first of all, it doesn't help you with subcortical mapping. That's not what it was for. It was for the cortical localization. But the reality is there's never been one study from any of those groups that have correlated that with direct cortical mapping in the operating room to prove that it's robust. But the other way to look at this is, if you want to do subcortical mapping, you can't use that intraoperatively.
Yeah. Maria, do you want to go down through some of the questions here?
Sure, sir. I will be happy to because there are plenty of questions in the Q&A and both the comment boxes. Sir, the first question is from Dr. Aristotelis Calus. He wished to ask, how do you integrate preoperative tractography into your intraoperative strategy? Do you primarily use it for surgical orientation and training, or do you rely on it for establishing robust anatomical relationships that guide your intraoperative decision making?
Yeah, I think it's a very good question. And in essence, I use preoperative DTI to define the motor and the language pathways. I incorporate that into navigation. And during the course of the surgery, I will use that only as a way to tell me when I am going to be close to those pathways cortically and subcortically primarily, so that I can begin my subcortical mapping. That's really critical. So I like DTI. I can't rely on it because it's an anatomical, not a functional localization strategy. So it helps you to understand when you can begin to do subcortical mapping. I don't use any connectomic data. I find connectomic data is useless. It doesn't relate to the actual intraoperative mapping data that we have, and I would never rely on connectomic data to determine whether a case is operable or not.
Thank you so much, sir. He has also asked another question. What preoperative mapping techniques, if any, do you utilize for SMA tumors, and how are they integrated into your intraoperative mapping strategy?
Well, I don't really do many SMA tumors awake. The only time I will do that in test language is if the tumor extends more than 4 centimeters from the midline, because then you're getting on the fringe of the middle frontal gyrus, which you must map with patients awake. So preoperatively, I don't do anything other than the standard battery of preoperative tests that I show intraoperatively. I show it to the patient preoperatively. That's all that I do. I do the preoperative DTI. I incorporate that. If the tumor is within 4 centimeters of the midline, I don't do it awake. I do all motor mapping in the SMA and in the motor cortex with patients asleep, because you can get a much more robust map with patients asleep, because when they're awake, the technique is way too sensitive and it will cause you to abort the technique before you should abort it, and you'll leave more tumor behind. So the sleep motor mapping.
There's a question, how about the importance and variability associated with the anesthesia team when transitioning between levels of consciousness? I thought that was a good question.
Yeah, it is a good question. And I will tell you, the anesthesia team can make or break your procedures. You have to have a reliable team. You have to have people you can work with. I suggest the night before, if you're working with somebody who you're not familiar with, make sure they understand the type of anesthesia you want to use, and that you need to be involved in the knowledge of the anesthetics that are being used. So during the timeout, I'll say to anesthesia, okay, we're going to do this case with propofol and remifentanil. And if that doesn't work, I'll tell you which drug to stop and how to proceed. So you have to be very, very careful, and you have to communicate with your anesthesiologist.
Maria, I think we have one more question maybe. How about transcranial magnetic stimulation and incorporating that in some of the mapping techniques?
Well, I think TMS is really very interesting. We use it preoperatively if we want to do navigated TMS and line up the points of TMS that we find on TMS on the MRI scan. We don't necessarily need to do that because DTI, I think, is very robust in terms of being, or allowing you or enabling you to know where the start and the end point is of a presumed anatomical pathway. You could do TMS if you want to find cortical localization. We're now using TMS postoperatively in patients who have any motor deficits to try and use TMS for motor rehabilitation, because there's very, very emerging good data from the stroke literature from Germany by Sandro Craig and others looking at TMS to rehabilitate the motor system with contralateral stimulation postoperatively. So we do use TMS for rehab, but not for preoperative localization.
Maria?
Sir, yes, sir.
Go ahead, Maria. Yeah.
Please, sir. I'm sorry.
No, go ahead, Maria. We got to wrap it up, I think, now. Okay.
Yes, sir. Please go ahead with this, sir. So, I think that most of the question have been already answered. Just a single question might be there, a couple of questions might be there, but please go ahead. We can wrap it up, I believe.
Okay. Well, again, want to thank Dr. Berger. I mean, this is just a magnificent lecture. So much to learn, continue to learn in a field that's so important for neurosurgery and neurosurgical oncology, and really happy to share this on behalf of the tumor section. I also want to thank the AANS. They've been really great partners now to help us with our educational initiatives moving forward. This talk will be posted on the tumor section website. So for those who haven't been able to take part today, this morning, you'll be able to see that later. Dr. Berger, thank you. Looking forward to seeing you soon, and I really appreciate it. Okay, thank you.
Thank you very much.
All right.
Pleasure.
Thank you very much, sir.
Bye.
Bye, sir.
Bye.
Pleasure. Thank you.
So much.